Hello everybody, welcome back to our second edition of ECG Insights. My name is Alex and I'll be our primary host for this series, and I'm joined by Dr. Abhishek Deshmukh. Thank you for joining us.
Thank you, Alex.
All right, and last session we had met with Dr. Alan Jaffe, and I'm really excited to walk through a handful of more of interesting ECG case studies and just kind of have an interesting conversation with the different ECG examples. To more kind of formally go into Abhishek's background, he is the medical director of the Heart Rhythm and Physiological Monitoring Lab, also known as HRPML, where we do a variety of different types of cardiac monitoring, whether you're talking inpatient, outpatient, or remote monitoring. He's the medical director of that area. He is also the co-director of the Clinical Cardiac Electrophysiology Fellowship Program. And he is the consultant at Mayo Clinic as an electrophysiologist within Heart Rhythm Services, also a significant outcomes researcher utilizing large data sets in order to ultimately assess quality, outcomes, and risk prediction for heart rhythm disorders, as well as performing invasive procedures such as ablations and device implants for AFib, ventricular tachycardia, infiltrative cardiomyopathies, and adult congenital heart diseases.
Thank you, Alex.
Yeah. So just a little bit about our learning objectives before we dive into some of our ECG examples. Some of the goals of this series is to identify key features of ECGs, including rates, rhythms, intervals, and waveforms, applying some of our basic interpretation skills, maybe even getting into a little bit advanced topics from time to time, and going through common arrhythmias and conduction abnormalities, also explaining our core concepts relevant to different roles within healthcare, and kind of going through some of their clinical significance. Before we dive into some of our case studies, one of the things that I always like to do is just walk through our, everybody might have a slightly different approach to ECG interpretation. And so just from our perspective, really just want to ask a question from your clinical expertise, what your fundamental approach is. I'll go ahead and start, and then just kind of based off of whatever I say, go ahead and provide your clinical expertise and how you would approach the ECG.
Absolutely, looking forward to it.
Okay. All right. So when first looking at a 12-lead ECG, one of the things that I like to do is first assess my measurements. You obviously have all of your waveforms that you see here, but your measurements will tell you a lot that you will verify with your ECG, but just based off your measurements alone, it will help guide you in the right direction for specifically when looking at your rhythm. So when you look at your heart rate, so both your atrial rate and your ventricular rate are the same. So the computer is telling you that you have a 1-to-1 ratio, 1 P wave for every QRS. So 1 P wave for every QRS complex. Your PRI measurement here is 176, which normal is 120 to 200. And then your QRS measurement falls below the normal measurement of 110 milliseconds. Your QTC, your Bazet formula, it's below that, kind of the first number that pops into my head is 470, especially with a narrow QRS, and that's sometimes dependent upon age and gender. But otherwise, your R wave axis, that usually falls -30 to +90. So the only thing that kind of sticks out to me in our measurements is that your 1-to-1 ratio falls below that normal heart rate of 60 to 100. As we look at our overall ECG, I see that our P wave, our QRS complex, and our T wave are all positive here in lead 1, and they're all negative here in AVR. If your limb leads are hooked up correctly, that is usually the case, but the main thing here is that your P wave and T wave are positive. Your QRS can vary depending upon what's going on, but your P wave and your T wave are going positive, and the exact opposite in AVR. You then have good voltage here in lead 2. One of the common indications is if you accidentally hook up your right arm and your right leg incorrectly, you'll have a flat line there in lead 2, and that ECG would need to be repeated. One of the other things I like to point out is that your R wave progression, starting in V1, you should have the smallest R wave here in V1, bigger S wave in V1 as well, and then by the time you get to V2, V3, your R wave should continue to get taller, and then by the time you get to V3 and V4, I like to call those your transitional leads. V4, you should have usually your highest voltage of your R wave, and then you should see your R wave slowly decrease in voltage by the time you get to V6, but then also your S wave should get smaller and smaller as well. And then you use your bottom 3 leads to interpret your rhythm and kind of help guide you into what your rhythm statement is, eventually analyzing any other abnormalities, looking for ST elevation, ST depression, anything else in terms of atrial enlargement, ventricular hypertrophy, various aspects of your ECG interpretation.
So thanks, Alex. This was a very nice summary. Just wanted to highlight a couple of points. Alex made a great point that if your lead 1, the P wave and QRS and T wave should be positive, and AVR, everything should be negative. And the reason behind that is whenever an activation is going towards an electrode, it makes a positive wave. And whenever an activation is going away from an electrode, it makes a negative wave. So your AVR is your right shoulder lead, and it is closest to the sinus node. So the activation is starting from there. That's why the P wave is always negative in AVR. The activation is starting from there. That's why lead AVR QRS is almost always negative. And the transition point, what you explained, V3, V4, where the transition happened, is the same concept, because your sinus node is somewhere in the top right chamber of the heart. Your V5, V6 are your lateral most leads. So all the activation is going towards V6, towards V5. So it becomes more and more positive. That's why V4, V5, V6 are predominantly positive leads. Same thing happens when we look at the P waves in the inferior leads. They are meant to be positive, because activation from this part is going towards your inferior lead. So anything going towards a lead is going to be quite positive. Now there are a couple of interesting findings here. So maybe we can go to the next page and talk about why these P waves look something like this, and then why does the V1 P wave looks like this. So when you think about the P wave in V1, so again you have to think about, say this is a great picture where your sinus node is somewhere here, and your lead V1 is on the right fourth intercostal space. So if your sinus is firing from here, part of the activation is going towards V1, and the rest of the activation is going away from V1 to activate the left atrium. That's why whenever you see V1 as a P wave, it has a small positive deflection followed by a small negative deflection. So that initial small positive deflection is the right atrial activation, and the terminal negative deflection is the left atrial activation. Now same thing can be looked at in this V1. If you see, this V1 is predominantly negative. That means your V1, the initial part is very small, you can't even see it, but terminal part is quite wide and negative. If that's the case, you need to think about why you get that terminal part, and that's your left atrial enlargement. So if your left atrium is enlarged, your terminal part of the P wave in V1 is going to be quite long and broad. Similarly, if you have right atrial enlargement, so you'll spend more time in the right atrium, so initial part of the P wave is going to be more positive compared to the latter part, which is going to be negative, which is the left atrial enlargement. So small tricks which you can looking at this can help you also identify some of the pathology. Another interesting thing you find here is AVF. This AVF is quite abnormal. If you look at lead 3 QRS, this is also quite abnormal. So now let's explain why this is happening. So as we discussed, whenever an activation is going towards an electrode, it makes a positive wave. That means if the activation is going without any hindrance, then you get a beautiful QRS. But if there is some slowing of electricity as it is going towards an electrode, or that can be because of scar, that can be because of prior MI, heart attack, all those things, this electricity is going to go slow, and that's the reason why you get this notching in this ECG, or notching in this lead in AVF, what you're seeing. That means from wherever the electricity is going towards AVF, it encounters some scarring or slowing of electricity. That's why instead of having a beautiful QRS like this, you are getting a little bit of a notched QRS. And if that's the case, as you know, AVF is the inferior lead. Look at lead 3. Even lead 3 is abnormal, because again, it should be a normal looking QRS. But here you almost see like 2 bumps in this QRS, again suggesting that there is some problem. Maybe this patient has some inferior wall scar which is causing this slowing of conduction. Mind well, this is not old inferior wall MI, because there you will get a Q wave, but this is an R wave, but RS R prime pattern and little bit of notching tells you there is some scarring in the inferior wall. But these are some of the things what you can glean from an ECG, and try to understand what could be the potential underlying pathology which is happening in this patient. Nice ECG, Alex.
Absolutely. Thank you for walking through that. So now we will move on to more of our ECG case studies where we walk through, I have about 6 ECGs to kind of walk through, and we'll just kind of take it one at a time.
Absolutely.
All right. So for ECG number 1, much different than the last ECG, but as we walk through some of our measurements, one of the first things that sticks out to me is that your heart rate's above 100. It also, your computer isn't giving you an atrial rate. That's kind of a red flag, or it was deleted somehow. And then also, you do not have a PR measurement. My brain is already going in a certain direction, potentially not sinus. You also have a QRS measurement that is very wide, potentially some type of IVCD, bundle branch block. We'll dive into the ECG to kind of talk through that measurement and see if it's accurate or not. But then also this QTC, just based off of the number 580, kind of a little bit of a red flag, and then also the axis is outside of our normal negative 30 to positive 90 as well. So very abnormal measurements on our ECG. So when we actually take a look at our ECG, there is a lot going on. And so when we talk about kind of normal positive and negative in our QRS complexes, we don't necessarily have that. Our T wave is positive here in lead 1. P waves are kind of hard to identify, potentially a P wave there, P wave there. We'll look at our bottom 3 leads to kind of help identify our rhythm, which may be leading to why there's kind of abnormal measurements on our atrial rate and our PRI. But our QRS is not going in the right direction, but our T waves are. Our QRS is going positive in AVR, but our T wave is also going negative, which the T wave is a normal finding. There obviously is an access shift in some of this and as well. But when looking at our rhythm in particular, we notice here in lead 2, if we're looking for P waves, you have things that are kind of almost like imposter P waves, where they are hard to identify or they are not very consistent. And so lead 2 isn't a great example. If you look at leads 2, 3, and AVF, if you take a step back and look at your ECG, I feel like you have a little bit of a sawtooth pattern. But when you look specifically at V1, I think this is probably one of the best leads when looking for atrial activity, specifically atrial flutter. Especially when you look at this break here from your R to R, you can identify a handful of flutter waves. And so based on just that factor, if you can march them out all the way across here, which you can, that would mean that your baseline rhythm would be atrial flutter. And if you don't take a look at V1, you might end up interpreting this as atrial fibrillation. But based on V1 and that pattern all the way across, being able to march that out, I think you can confidently interpret that as atrial flutter. I feel that you also have a right bundle branch block, which you can confirm here in V1 with that RSR pattern, or the R prime. And then you also have what would appear to be a fascicular block pattern where you have that R, small r, big S, maybe an itty bitty Q wave here, it's hard to see, and then a big R wave here as well. So you are looking at a right bundle branch block, a fascicular block, meaning that this would be a bifascicular block as well.
Great. So there's certainly a lot going on this ECG.
Absolutely.
Can we go to the next where you have the picture of the heart?
Absolutely.
That's great. So again, Alex showed that V1, which has a lot of these organized P waves. And you would argue that, a lot of times patients are in AFib, not in this ECG, but you still start to see a lot of these organized P waves in the V1. And people call it different names. They call it flubber, they call it flitter, they call it coarse atrial fibrillation. But there's nothing like that. It's all atrial fibrillation. So let's think why that happens. So again, lead V1 is your right fourth intercostal space. And if you open up somebody's chest and see the first structure which comes out is the right ventricular outflow tract. And right behind that is the right atrial appendage, which is an anterior structure somewhere here. So your V1 being so close to the right atrial appendage is picking up, the V1 is picking up all the signals from the right atrial appendage. Now, right atrial appendage is a very muscular structure. It's a very large structure. So because of that, it creates a bigger voltage compared to, say, somewhere else, say, example, V6, which is so far away from the atrium anyways. So that's why sometimes it is very common to see AFib being or A flutter being more prominent in lead V1 just because it is so close to the right atrium and more specifically to the right atrial appendage where it can make a bigger voltage compared to say V6 or V5 which are so far away from the atria. Now if you go back to the prior ECG, as you have nicely shown out that these flutter waves will march. And whenever something marches, as you know from military, it is an organized rhythm, right? If somebody is not marching correct, it is a disorganized person or disorganized rhythm. The fact that you can march these flutter waves out tells you this is a more organized arrhythmia, and an organized arrhythmia is likely going to be atrial flutter. Now case in point, again, if you see V1, it looks nice and sharp, these P waves. Look at V5 and V4, it is so flat, you can't even know which wave is what. So that's again, it is so far away from the atrium, that's why you don't get a bigger voltage, that's why it looks quite flat. If you look at the inferior leads, it is kind of giving you that sawtooth type appearance. So again, this might be more consistent with atrial flutter as you pointed out. Now the interesting thing is right bundle branch block. And you know, Alex, you have seen ECGs all these years. You know, we always talk about rabbit ears, right?
Yep.
This is one part of the rabbit ear. This is the other part of the rabbit ears. If you look back at all the ECGs you have seen, you know, if you look at a rabbit, their ears are of the same level and same size. But if you look at right bundle branch block, all the rabbit ears are of different sizes and shapes.
Absolutely.
So, you know, we need to understand why those rabbit ears are of different sizes and shapes. So if you can go to the next screen, think about why you get a right bundle branch block. So this is your axis, sinus node, AV node, His bundle, right bundle and left bundle. So this we'll call it right bundle, this we'll call it left bundle, and we are looking at lead V1. So if the right bundle is blocked here, that means the electricity is going down the right bundle, so that gives you that initial R wave. But because it cannot go down further, the electricity turns back, goes to the left bundle, depolarizes the left bundle, which is the more dominant vector. That's why you get a small r, deep S, which is the LV activation, and then you get the terminal R prime, which is basically the delayed RV activation. So this delayed RV activation, the R prime is almost always quite wide because it is all muscle to muscle conduction compared to fascicular conduction, what you go over the right bundle. So that's why the initial part is quite brisk. The middle part is quite brisk, but the terminal part becomes quite wide. And then you can potentially predict the width, how tall this R prime is, and that can also tell you a lot of things. So if that R prime is quite tall, that tells you your RV is quite enlarged or you have RV hypertrophy. So if you go back to the ECG again, if the RV is quite enlarged or if it is hypertrophied, it is going to shift the heart more rightward. And that's your clue why you have right axis deviation or almost an ECG consistent with left posterior hemiblock, because the right ventricle is quite enlarged and just shifting the heart towards right side. So this is a very nice ECG which illustrates a lot of concepts about flutter, how to differentiate flutter from fib, why you see a prominent flutter waves or even fib waves in V1 compared to some of the leads which are further away from the right atrial appendage. All right bundle branch blocks are not the same. If you can see, small R wave, S wave, but a huge R prime. A huge R prime is your marker that there is something wrong with the right ventricle. Maybe it is enlarged, maybe it is dilated, maybe it is hypertrophied, more likely to be hypertrophied. And if that's happening, it is moving the heart more rightwards, and that's why you're getting this right axis deviation. Few other things to remember on this ECG is there is a PVC. So, so that just tells you that you have all these things going on with a PVC, just probably a more sicker person or a sicker heart. And different kinds of PVC, that's again a marker that there is some sort of underlying cardiomyopathy going on. But great ECG and lots to discuss on this ECG.
Absolutely. So from a clinical perspective, if a patient comes into the clinic and this is their first time having atrial flutter, if they were very symptomatic, they would probably be cardioverted and their care would be kind of tried to be stabilized. But at what point does a patient come to you in the cath lab to potentially get like an atrial fib, atrial flutter ablation?
Yeah, no, great question. So if you look at this ECG, even before you see the patient, if you get a chance to look at this ECG before seeing that patient, you know there is a problem going on with the patient. There is an arrhythmia, their right ventricle is enlarged or hypertrophied, they have different kinds of PVC, so slightly sicker heart. Now, if the patient says, I'm symptomatic with this arrhythmia, then we can treat them with medications, we can treat them with ablations and potentially hope to get rid of this flutter. But a lot of times if patients have atrial flutter or atrial fibrillation, it kind of creeps up on them. It's like having a bad back or a bad knee. It just creeps on you, but you only know how good you can feel once you get rid of that. So it's tough to treat chronic back pain, but chronic knee pain, but cardioversion is a very easy thing to do to get these patients off atrial flutter, atrial fibrillation. And if they feel really good in normal rhythm, then you can get more aggressive with invasive treatments and drugs and everything else to prevent them from having a recurrent fib flutter. Now, but looking at this patient, because you already have identified this is a sicker heart, we would need to do more detailed evaluation, like is there truly right ventricular hypertrophy, why is this patient having PVCs, Holter, make sure they are not having atrial fibrillation in the background. So this will require an in-depth discussion with the patient before we do, we offer treatment options.
Absolutely. My last question for this particular ECG, so we definitely have abnormal ventricular depolarization happening. One of the statements that we often utilize is secondary STs and T waves. In terms of when you have abnormal depolarization, it's oftentimes normal to have abnormal repolarization, which is highlighted here in V1, where your T wave and your ST segments are down, where you have that concordant ST and T wave depression, which we identify as secondary STs and T waves on an ECG.
Right. So this would be more consistent. So you will, if you have a patient with right bundle branch block, you will always have a deep S wave in V6. So that's basically V1 is right fourth intercostal space, V6 is your posterior most lead what you have placed, and they are giving you the same information, but they are just flipped. So if you have a tall R prime, you'll have a deep S wave in V6. So so you will always get that. Now, as far as the ST segment changes are concerned, you have a right bundle branch block and your ST segment and T waves are inverted, which is normal because this is almost like discordance, right? With your bundle branch block, if your QRS is positive, ST segments are going to be ST segments and T waves are going to be negative. If your QRS is negative, then the ST or the T wave is going to be positive. So this kind of follows suit on what we are seeing. But the fact that this T wave is a little bit too inverted or too depressed for my liking, again, may suggest right ventricular strain pattern. That's what we have identified from the R prime, from the right axis deviation. So kind of everything kind of falls into place to find out why this patient has this finding and probably might have had COPD or something like that.
Absolutely.
Another point you brought out was QRS being 202 milliseconds. So we know that the QRS is wide. And when you think of QRS being wide, it's important to know what happens to the QT interval. So if you think of QT interval, what it is that it has a QRS and a T wave. So onset of the QRS to where the T wave joins the baseline is your QT interval. That is basically your QRS interval plus your JT interval is going to give you the actual QT interval. Now, normal QT interval we know is about 460, 470 milliseconds, but in patients with bundle branch block, it might be inflated because QRS plus JT is equal to QT interval. So if your QRS is wide, as you have seen 202 milliseconds, and say normal QRS is 120 milliseconds, you're already getting a lot of extra points or time on your QTC interval because of this prolonged QT, because of this prolonged QRS. But there are some corrections you can do to correct for prolonged QRS, such as in patients with bundle branch block, patients with pacing, left bundle branch block. And that is just look at the measured QRS, so say about 200 milliseconds, subtract that from 120 milliseconds, which is your normal QRS, that would be 80 milliseconds. And then you can deduct that 80 milliseconds from your QTC, what the machine is giving you or what you're measuring. So this will be around 500 milliseconds would be the corrected QTC for this particular patient. Again, this is a little bit challenging because the heart rate is quite irregular. The irregularity can also change the QT interval, but in a patient with sinus rhythm, this can give you a nice example how to correct for a corrected QTC interval.
Absolutely. So definitely, needless to say, there's a lot going on in this ECG.
Yeah.
So thank you for walking through all of that. We'll move on to our next one. So then when looking at this ECG, going through our numbers look a little bit different. This is more of our PDF view of these numbers here. You have a normal heart rate. You do have a long PRI being over 200 milliseconds. Your QRS is also wide at 154. QTC is also wide. It's above that with the QRS measurement of being wider than 120. Greater than 500 is a prolonged QT, and then our negative axis, our R-wave axis, is also negative 72, which falls outside of our negative 30 to positive 90, but there's a reason for that. So when walking through this particular ECG, we see positive here in lead 1, we see negative here, the T wave is negative here in AVR, but then when you look at lead 2, 3, AVF, all of our QRS complexes are going negative, which is contributing to the fact why our R-axis is outside that normal range. When we look at our R-wave progression, trying to go from mostly negative here in V1, trying to see it transition here to get R-wave getting taller, R-wave getting taller, that just simply isn't happening. And so you have no R-wave progression really throughout any V1 through V6, but if you look really, really close, one of somebody's first instinct when looking at this might go, this kind of looks like a left bundle branch block almost. But when you look really close here in even V2, it's hard to see, but V3 has a great view of it. You see that little spike in the QR at the beginning of the QRS complex, a little bit also here in V5. V6, this patient's rhythm is actually ventricularly paced, which is the reason why your QRS complex is wide. Your PRI might be purposely programmed to be delayed. And since we're ventricularly paced, your axis, it's understandable to see that your axis is also not normal, considering that it's being paced. But when you look at your rhythm overall, you do have consistency between your P wave and your QRS complex. So we do have a synchronized atrial sensed ventricular paced rhythm all the way across. And so we do have AV synchrony, but otherwise overall, atrial sense ventricularly paced. What else would you add, Dr. Dashmukh?
Oh, that's great discussion. So, as you brought up, it's always when you see this V1 and you don't see the pacing spike, and it's hard to see the pacing spike here. One thing you would always wonder is this left bundle branch block, and very legitimate concern that can this be left bundle branch block. There are a few things on this ECG which can tell you this is not left bundle branch block. If you have high astigmatism like me, even I couldn't pick up the pacing spikes. So I'm amazed that you picked up the pacing spikes. But I can pick up the physiology of that this is not left bundle branch block by some key points if you can allow me to explain. So can you go to the next anatomy thing?
Oh, there are settings here. We'll go back to that.
Perfect. So again, we'll go back to the same picture what I drew. SA node, AV node, bundle of S, right bundle, left bundle. So now the story here is opposite. The left bundle is blocked. So because of that, the electricity can go down to the left bundle, proximal left bundle. It sees it cannot go through. So it goes to the right side. The septum gets activated from right to left. And then it goes to lead V5, V6, V4, lead 1. So whenever an activation is going towards an electrode, it makes a positive wave. Activation going away from an electrode makes a negative wave. So as your activation is all going towards the lateral leads, 1, AVL, V5, V6 are all going to be quite positive in patients with left bundle branch block. Another thing to remember is that there is no problem with the sinus node and the initial ventricular activation. So as the activation is starting still from the sinus node, your AVR in a patient with left bundle branch block is always going to be negative. So this is how a typical left bundle branch would look like. You'll have 1 AVL, V5, V6 all going to be positive. AVR is going to be negative. Now if you think about this particular ECG what we have, the V1 to V6, everything is negative. Inferior leads are also negative. But if you go back, and we'll go back to this ECG, AVR, however, is positive. So first thing to think about when AVR is positive are the left and right electrodes misplaced. But they are not, because lead 1 is still positive, which is normal. So why would AVR become positive? And boils down to the same concept. Activation going towards an electrode makes a positive wave. Activation going away from the electrode makes a negative wave. So this patient has a pacemaker in the right ventricular apex. So all the activation is all starting from this whole apical area. That's why you see all these leads completely negative, V1 to V6, and everything being negative in the inferior leads. Yet your friend is your AVR, because if you are stimulating the ventricle here, the activation is going towards AVR, activation is going to go towards AVL, activation is going to go towards lead 1. So that's why in RV pacing, AVR will be positive, AVL will be positive, and lead 1 will be positive for RV pacing. Now if you go back to our ECG again, if you see AVR is positive, AVL is positive, everything else is negative, so activation is going towards AVR, towards AVL. That means it has to start from the inferior part. And that means the ventricle is abnormally depolarized, and the only way you can have this pattern is that if you're pacing in the right ventricle. So this is a nice example to show that if you don't see the pacing spikes, you may wonder whether this is left bundle branch block or no. Your friend is AVR. If AVR is positive, why is the AVR positive? Look at the leads if they're interchanged, but no, even 1 is positive. Well, 1 is positive, AVR is positive, AVL is also positive. That means the only leads where the activation is going is AVR, AVL, and lead 1, and that means the activation is coming from somewhere else, and this would be somewhere else would be RV apical pacing in a patient with, say, a heart block, or if they have a pacing requirement. A nice ECG which kind of illustrates the concept of vectors on an ECG.
Absolutely. So then the next just image to this particular patient. So same patient, they had a MCT vent or a Holter ordered, where you can see, here I'll just erase some of this so we can kind of start fresh on this guy. There we go. So when looking at this particular ECG, this is the same patient, and at the beginning of the ECG, you can kind of clearly see that atrial flutter type rhythm. We then convert to a sinus rhythm with some AV pacing every once in a while, but you see here, this is more of an atrial paced, ventricular paced, and then we have atrial sensing, ventricular paced, atrial sensed, ventricular paced, and then we atrial pace, ventricular pace again. So kind of a combination of the patient converting from atrial flutter into various forms of AV pacing.
Yes, and I think now you can know the indication for the pacemaker is probably sinus node dysfunction also, because you are pacing in the atrium likely in this patient, and that can happen when the flutter stops. Because what's going on in this flutter, the atrial rate is about 300 milliseconds. Or about 280 milliseconds, or about 320 milliseconds in this particular patient. So once that happens, your atrium is going at, say, 300 beats per minute, and it is suppressing the sinus node. Now once the flutter stops, the sinus node still feels suppressed and depressed with all this flutter going on. So it takes time for it to wake up. So that's basically called as sinus node recovery. If that sinus node recovery is delayed, then you can get a long pause, which is not uncommon to see when, say, flutter terminates, or when you do cardiovert a patient, or they spontaneously go back into normal rhythm, you will have some pause, 2-3 seconds, which is generally benign. But if you have longer pauses and patients have symptoms, then they would need a pacemaker. This is also interesting here that after the flutter terminates, it takes time for the AV conduction to restore again, and then hopefully by the end they have a restoration of the AV conduction. But nice ECG which kind of highlights again why this flutter waves, atrial pacing and the paced ventricular morphology.
One other question. So when a patient has a device already and they're ordering an ambulatory monitor, the patient is maybe known to go in and out of atrial fibrillation. From a clinician standpoint, what are some of the things that they're looking for when analyzing some of the aspects of rhythm interpretation that when they already have a device present and everything?
Right. So great question, because your your device diagnostics will give you data on arrhythmias. They'll talk to you about ventricular tachycardia, atrial fibrillation burden. But the device may not always differentiate whether this is atrial fibrillation or is it atrial flutter. But a 12-lead ECG or an ambulatory monitor can differentiate, because now there are clear P waves or clear flutter waves. So this should be more consistent with flutter. That's number one. Second, you can also look at Holters or ambulatory monitors to look at the PVC burden in patients with pacemaker or ICDs and all the other devices. So the device or the pacemaker report will give you the PVC burden. That may not always be accurate, or that may be accurate because it is going to give you over a period of time, but Holter will be more snapshot, 24 hours or whatever duration you are wearing the Holter. But more important, it will give you the morphology of that particular PVC, which the pacemaker or device interrogation cannot give at this point. So Holter has its own unique advantages. So for example, somebody has a CRT device and they are having frequent PVCs. Holter can tell you what's the PVC burden. It can tell you where these PVCs are coming from, if there are many different kinds of PVCs, and all those things are quite helpful from an ambulatory monitor in patients with the devices. So it does have a very important role still, although the device diagnostics can give you a lot of information.
Absolutely. Anything else on this one?
No, great. Thank
you. All right. So then now our next ECG, which is an interesting ECG. So going through our measurements, we have a normal heart rate, so falls between that 60 to 100. Our PR interval is just below the 120 to 200 mark, so I'll just kind of make a note of that. Your QRS is just slightly wide. I don't appear to have any concerns about our QTC. However, our axis does fall slightly outside of our normal negative 30 to positive 90. When now focusing on our ECG, comparing some of these numbers, you notice that your P wave, your QRS, are positive, your T waves are slightly flat, but for the most part, most of your complexes are going positive. Maybe make note of the T wave abnormality there, but then your P wave, QRS, and T wave are going negative here in AVR. When another thing that sticks out is that in leads 2, 3, and AVF, all of your complexes are going negative and may be contributing to the reason why we have a slight axis change. And then also looking at our R wave progression, we start out mostly negative here in V1, and then we quickly transition over to V2 where we go more positive. By the time we get to V6, we have that very small S wave, so kind of a normal, pretty normal R wave progression. But one of the things as far as why the PR interval is short and why the QRS might be slightly wide kind of speaks to maybe something that we're dealing with, some pre-excitation. Mm-hmm. Can you dive a little bit deeper into that?
Yeah, absolutely. The great ECG. Can we go to the next slide here?
For the physiology?
Yeah, let's look at this now. So again, this is like my favorite diagram to draw today, it seems. So yeah. SA node, AV node, right bundle, left bundle, and in the middle is the His bundle. Now the reason why we get a normal PR interval or any PR interval is the electricity starts from the SA node. So the first part of the atrium to get depolarized makes that P wave. Then this wavefront travels through the atrium, through the AV node, through the His, through the bundle branch blocks, and it exits on the first side of the LV septum. So this entire journey gives you that PR interval. So PR interval is basically atrial depolarization and timing in the AV conduction system till the time the QRS is formed. This whole thing gives you a PR interval. Now, but most of the delay or most of the PR interval is given because of the decrement in the AV node. That's why when we think about first degree AV block, PR is more than 200 milliseconds. In Wenckebach, Mobitz type 1 AV block, PR gets longer and blocks. That Absolutely. Just tells you that the AV conduction is slow or the conduction is slow in the AV node. Now, whenever you have a short PR interval, so P wave followed right by a QRS, even before you look at the QRS to find out whether it is pre-excited or slurred or not, look at why should the PR be short? Now the PR is short in a patient with pre-excitation because the activation is not going down the AV node. Because from atrium, it can find an accessory pathway and go to the ventricle right away. So P wave and the QRS is right here. Normally you get a QRS because the activation goes down the His-Purkinje system, and then the first part of the ventricle to get activated is on the LV side of the septum. But wherever the accessory pathway can be located, wherever it inserts onto the ventricle, that will be the first part of the ventricle which gets activated. So that's why the whole journey of the atrial depolarization to reach the ventricle is much longer in patients with normal conduction due to AV node than in a pathway, because the conduction just goes from atrium to the ventricle through this accessory pathway, bypassing this whole thing. That's why you get a short PR interval in patients with the pre-excitation. Next, you need to understand why you get this pre-excitation pattern and why sometimes the pre-excitation pattern can be quite variable. And for that to understand, maybe can we erase this again?
Yeah.
And for that to happen, you need to understand why we get a QRS. So normal looking QRS is basically summation of LV activation and RV activation, because the QRS activation goes down the SA node, AV node, bundle of His, and depolarizes the ventricles right and left and right, depending on how it is getting depolarized. So the QRS is basically summation of LV activation and RV activation. Now the initial part of the QRS is almost always quite brisk, and that's because the conduction is going down the bundle branch blocks and His-Purkinje system. Now in accessory pathway, it is a little bit different. So for example, if there is an accessory pathway here, the atrium sinus node fires, and before even it goes to the AV node, the activation can go down the accessory pathway, activates this part of the QRS, and makes that and slurred delta pattern. So if the activation is going completely over the AV node, you get a normal QRS. If the activation is going completely over the accessory pathway, you get a slurred QRS or a very manifest pre-excitation. But a lot of times it's a race. Who is going to win the race? Sometimes the AV node wins the race, then you get a normal QRS. Sometimes the accessory pathway wins the race, so you get a very slurred and wide QRS. But sometimes they fuse because they just come down at the same point, so it neither looks like a pre-excited beat nor it looks like a normal QRS. It looks a little bit in between beats, so almost like a fused beat, what you can get if the accessory pathway is not very strong or robust conducting. Now, if you have this accessory pathway, now you have to understand why is it slurred and why it is not sharp like this. Like we talked about, the sharpness is because of activation going down the His-Purkinje system. When you have an accessory pathway, there is no His-Purkinje system. It is bypassing this whole thing. That's why it's also called as bypass tract, because activation just goes from the atrium to the pathway to the ventricle. So this sharpness which you get because of His-Purkinje system is not there, and that's why it looks more slurred in an accessory pathway type ECG. And looking at the vectors, again, activation going towards an electrode makes a positive wave, activation going away from the electrode makes a negative wave. You can also kind of point out where the accessory pathway might be located. So if you can go back on your screen, if you look at this, your transition is off because V1 is small r deep S wave, but look at V2, very tall R wave and a small S wave. V3 also very tall R wave and a small S wave. So this break in transition is also occurring because the activation is not going down the His-Purkinje system. It is bypassing some other way by which the ventricle is getting activated. That's why you have a break in normal transition. Now just for some advanced learners who, or trainees in cardiology or EP, as you can see, the inferior leads are negative. That tells you that this is probably an accessory pathway coming from somewhere inferior wall or posterior part of the septum, probably on the right side. But this negative delta wave in lead 2 is very classic, that it is coming from the middle cardiac vein, also called as epicardial pathway. So just something to think about. But again, if you apply the same vector principles, you can identify these pathways and everything else. So one other point I wanted to make here is that, some people will say, well, I don't see any R wave. Is there an old inferior wall MI? And, good thought, that can happen. But again, look at the slurring. The slurring is quite wide. So, you won't get that kind of slurring in patients with inferior wall MI. Second, you get the Q wave because the inferior wall is dead, but if it is dead, it's not going to make such a big voltage what you're seeing in lead 3. So that could be another marker. And third thing, the PR is quite short. So again, in patients with MI, the PR might be normal or sometimes even a little bit longer in patients with inferior wall MI. So these are the kind of things you can think about when you're analyzing this ECG. Nice
Absolutely.
ECG.
Yeah, so that was going to be one of my main questions in terms of, so probably not best to call this an inferior
No.
infarct, maybe more just left axis deviation
Yeah.
because of the pre-excitation.
Yeah. And you cannot even call it left anterior fascicular block, although the axis is not that leftward, because you don't have an R wave here. You need to have a small R wave in the inferior leads to call it a left anterior fascicular block.
For this particular patient, it's their first time being diagnosed with WPW with that accessory pathway. What are some of the risks that that patient may have?
So when you approach somebody with WPW pattern on ECG, it's important to get a history, whether they have palpitations, whether they have passed out, any arrhythmias what they have seen. Because if they have that, then certainly we can think about offering them treatment to prevent them from having arrhythmias, or mapping where these accessory pathways are located, and then we can potentially ablate them for them to be relieved of this accessory pathway. So a lot of things can potentially be done for these patients.
All right, so maybe this could go wrong for the patient.
Yes, so this is an interesting ECG where this patient went into atrial fibrillation. And again, when we talked about the QRS in a patient with accessory pathway, I told you it's a race between activation going down the AV node and activation going down the accessory pathway. And if you look here, there is no narrow QRS. So that tells you it is all going down the accessory pathway. But sometimes you will see it becomes even wider and bizarre when it is going much faster. And that is one of the markers that this patient could be at a risk for sudden cardiac death. So the way the patients with accessory pathways could die is that if they get an atrial fibrillation episode where the pathway is winning the race all the time, so activation is going down the pathway, and here it goes quite fast, so ventricle is beating so fast that this potentially can result into VF. This is also one of the reasons why, if you don't give adenosine in a rhythm like this. Because what adenosine is going to do, again, if you have atrial fibrillation going down, and all this conduction is going down this accessory pathway to the ventricle, and sometimes it is fusing and going down the AV node. If you give adenosine, or if you give beta blockers or calcium channel blockers or verapamil, you're going to acutely block the AV node. So there is no other way for all this AFib to go down to the ventricle except the accessory pathway. And if the atrial rate is 200, 300 beats per minute in atrial fibrillation, the ventricle will also go at 200, 300 beats per minute, as you are seeing here, and that can potentially degenerate into ventricular fibrillation. That's why the standard teaching is that if you have an accessory pathway and the patient is in atrial fibrillation, don't give adenosine, because you're going to block the AV node and everything will go down the accessory pathway.
Absolutely. So then say the patient, in this particular ECG, same patient, we end up getting that ablation. And we can see here that our ECG looks much different. Our measurements, we have our normal heart rate, our PRI is normal, our QRS is normal, and that accessory pathway and that delta wave completely disappeared.
I mean, the first thing you see, the PR interval kind of is there now. Initially, there was no PR interval, so now at least you have a PR interval. You can see the onset of this initial part of QRS is quite brisk. That's because the activation is going down the His-Purkinje system. So that's again, and you don't see an obvious delta wave. So that's your marker that the accessory pathway is gone. And remember how negative the inferior leads were?
Yeah.
And now they are all normal looking, actually quite small in amplitude also, again suggesting this accessory pathway is gone. So I hope the patient did well after this.
Absolutely. Fourth example, kind of on a similar topic here. So I just will, rather than going through all of the measurements here, you had talked about how sometimes it's a race.
It's a race.
You have sometimes how one of the things that I was unaware of is that WPW or accessory pathways can sometimes be like dormant or can be intermittently activated. And so I think this ECG is a perfect example of who's winning the race with each beat.
Yeah, if you just go from here, look at the PR interval is quite short and the QRS is quite slurred. So activation is going down the accessory pathway. Next beat, you have a PR interval which is present and the delta wave is gone. So again, so this will be going down the accessory pathway. The second beat went down the AV node. I'm trying to see if we have an example where it is little bit fused, and I'm not convinced we see it. Maybe, no, I don't want to imagine anything. EP doctors are notorious to imagine P waves and pathways, but I can't imagine also anything here. But sometimes you'll find a beat which is in between this QRS and in between this pre-excited beat, and that would tell you that the activation is going down both the AV node and accessory pathway. But in this patient, it's quite interesting. It goes one time over the AV node, second beat goes over the accessory pathway. It's actually these two beats goes over the accessory pathway, and then the next beat goes down the AV node. So nice ECG to show that. Well, I think, Alex, I think I can imagine now. Look at this delta wave and QRS. This is a little bit wider compared to, say, this one. You may not buy it, but for my eye, it looks a little bit wider. Yep. So this tells me this is still fused between the AV node and pathway. Pathway is winning the race, but here the AV node is blocked and it's all going down the accessory pathway. So this is why sometimes the QRS can be slightly variable.
Yeah.
Nice.
And so sometimes there are patients that could probably go a very long time without WPW ever, or these pathways presenting itself, and then that race starts to happen more and more, and then maybe the patient starts having symptoms and palpitations, and then we can finally identify this.
Yeah, I mean, patient who has an isolated accessory pathway, if they don't have any arrhythmias, they are not going to have any symptoms from just having a pathway. But if they have an arrhythmia and those kind of things, then they are going to be more susceptible. And they will be at a risk of arrhythmias, because now you have two ways by which the electricity can go down. One is an AV node, one is the accessory pathway. So then there's always a chance that it can just go over the accessory pathway and climb up the AV node, that is antidromic reentrant tachycardia, or it can go down the AV node and climb up the accessory pathway, that would be orthodromic reentrant tachycardia, so ORT. So because of pathways, now you have two ways of going up and down, and that's why these patients are at a high risk of arrhythmias.
All right, moving on to our next ECG. So when looking at, it's pretty busy. It's got a little bit of artifact here in lead 2. But when we look at our measurements, we have a normal heart rate. Our PRI has an asterisk by it, so the computer's having a hard time with consistency or identifying consistent P waves all the way across. Our QRS complex is wide. Our QTC is 470, but with 478, but with our wide QRS complex, that's not super abnormal. And then our axis falls outside of that -30 to +90. When we look at overall at this ECG, similar features compared to one of the previous ECGs that we had looked at, but overall, your rhythm on the bottom 3 leads is from QRS to QRS is irregular. You do have P waves, but when you look at your PRI, there is no really, there's a P wave inside the QRS complex. Kind of the PRI is all over the place, but it does have times where it looks like it is synchronizing, but sometimes where it doesn't, and you overall have irregular R to Rs. This is a little bit easy. In this ECG, it's a little bit easier to see. Your computer system helps identify with your pacemaker spikes down here at the very bottom, and then you can look up at your leads here. You can see a pacemaker spike here in V1, V2, very much so here in V3, a lot more here in V4, V5, and V6. So this is a much easier to identify from a pacemaker
Alex,
standpoint.
do you know why the pacemaker spike in V4 is the biggest you're seeing here?
Because that's the closest to your ventricles.
Exactly, because this is your
V4 is closest.
your V4 is the apical lead, and your pacemaker is somewhere here. So this is the closest lead. That's why your pacing spike is so prominent in V4 compared to V1, which is so far away from your pacing, from your actual place from where you're stimulating the heart. So that's why your V1, you don't even see a pacing spike. Lead 1, you don't see a pacing spike, but despite all this artifact, V4, you're still able to see a pacing spike because it's just so close to it. Now you may wonder, why there is no consistent AV synchrony, because then you need to understand what kind of pacemaker the patient has. So if a patient has dual chamber pacemaker, meaning a lead in the atrium, lead in the ventricle, even if they don't pace the atrium, they can sense the atrium, and once they sensed an atrial event, once they sense an atrial event, the pacemaker initiates what we call as AV interval, and in that, if the patient does not get a ventricular event, you get a pacing spike followed by ventricular capture. But in this, and that will all be consistent. But in this patient, you see sometimes you have good AV synchrony, meaning for every P wave sensed, there is a fixed PR interval and then you get ventricular pacing, so it looks pretty good. But sometimes here you don't have it. So why will a pacemaker work for few beats and not work for few beats? It is bizarre, it won't happen if a patient has a consistently working dual chamber pacemakers. Now, can this happen because the pacemaker mode is programmed wrong? Probably not, because if your programmed mode is DDD, so you are sensing and pacing both in the atrium and ventricle. If that's the case, you will have clear P wave and QRS timing. But sometimes, some novel devices, or for leadless pacemakers where you don't have an actual atrial electrode, but it is picking up an atrial activity by several different methods, that may work sometimes, may not work sometimes. So for example, probably did not pick up this, but you still got ventricular pacing. But here there was good AV synchrony. So this sometimes can happen in patients with certain types of leadless pacemakers who don't pace in the atrium and who actually don't have an electrode in the atrium to sense, but they can figure out an atrial activity due to several of their algorithms which are programmed in. This can also happen in pacemaker or ICD leads which have an atrial sensing electrode. So if that atrial sensing electrode doesn't pick up the atrial activity, you will still see pacing because if the patient is dependent on the pacemaker, but the PR interval can be variable as you have shown here.
Absolutely.
But one clue here again, is this left bundle branch block or pacing? Your V5, V6 are negative. So in left bundle branch block, V5, V6 will always be positive. And your AVR is positive. In left bundle branch block, AVR will always be negative. So again, this is an example of paced rhythm and not left bundle branch block.
All right, last one. So this is a strip from our inpatient telemetry group. So we don't have a full 12-lead ECG to kind of analyze this, but we do have, here we have lead 2, V1, lead 3, and V3. So one of the things that we can tell about this ECG, you can clearly see P waves, especially here at the beginning, you see P wave, P wave, P wave, and that's pretty consistent up until we get a change in morphology right here, and then all of a sudden our rhythm takes off to right about there, and then we're back to normal as our normal beats are identified here. Now, when you look at this ECG, your QRS complex looks slightly wide here in your normal beats, but then all of a sudden your rhythm takes off. Mm-hmm. How do we walk through this example?
Yeah, so the big question here is this rhythm a VT or is it some sort of SVT? Because that's going to have clinical implications for this particular patients. So let's look at this PR interval. So every P wave there is a QRS, looks pretty good. And then suddenly you see this P wave is different than this P wave, and then the tachycardia starts. So that tells you this is an abnormal P wave, so probably a premature atrial beat or a PAC or something like that, which is initiating the tachycardia. So that means the tachycardia is starting in the atrium. So one marker that is likely going to be an atrial arrhythmia. Second, if you look at the QRS, it kind of is very similar to what the underlying QRS is. If you have VT, there's one abnormal part of the ventricle which is firing, so that QRS is going to be very different compared to the normal QRS. So this QRS is of the same family, it looks very similar to all the things what we are seeing here, and that would be all consistent with some sort of SVT rather than a VT. But if you want to take it up a notch more, you can see now the P waves are somewhere here. You can look at these P waves, and there is no AV dissociation. In VT, you're probably going to have more AV dissociation than in SVT. And when the tachycardia stops, there is no P wave here. So that's again a marker. This is likely going to be some sort of SVT, some either atrial tachycardia or some of these rhythm. Another thing you can potentially look at is that sometimes the transition, the tachycardia becomes a little bit faster here compared to here. And that is because the atrial activity is becoming faster. So again, the atrium is driving the ventricle. That's again your clue. This is some sort of an atrial arrhythmia and not a ventricular arrhythmia. So if this, I see it on telemetry, I would be thinking of some non-sustained SVT or non-sustained atrial tachycardia.
Absolutely. So when patients are in the hospital, maybe they're getting worked up for like an SVT ablation. Is there any difference when a patient's worked up for an SVT ablation versus like an AFib, VT ablation?
Yes.
What's the difference?
Yeah, so I mean, it's a big process because ventricular tachycardia typically would occur in patients with structurally abnormal heart. So you need to know where that abnormality is present. Ventricular tachycardia can also occur in patients with structurally normal heart. That would be like an outflow tract PVC or outflow tract VT. So it all depends what kind of QRS you are seeing. Second, from an AFib ablation standpoint, you need to know the pulmonary veins, and there's a more detailed evaluation in that. SVT ablation, if you need to have a tachycardia, and then the EP study is going to tell you what kind of arrhythmia you're going to see to map and ablate. So, every procedure is going to be different. Not all ablations are the same, and every ablation will have its own nuanced things when we do them in our labs.
Absolutely. Anything else to say about
No,
this
it
one?
looks good. Great.
All right. So that ends our session today for ECG Insights. We talked about a variety of topics. If you have any questions, feel free to reach out. Dr. Deshmukh, it was a pleasure to have you. Look forward to doing it again.
Absolutely. Thanks a lot. Thanks,
Thanks,
Alex.
everybody.
Thank you.